Randa. Do you need to?
Well, I was just emailing you back. I got it. So there must be like a glitch.
Angela, are we ready to go? Yes. All right. So I hope everybody can hear me. It's 4:01. We've given our traditional 1-minute lead time. It's my pleasure to introduce our speaker today. Dr. Eldin is a medical graduate of the University of Khartoum in Sudan. She finished her internal medicine residency training at St. Francis in Evanston and is now one of our second-year endocrine fellows. Today she's going to be talking about adult onset hypophosphatasia. So Randa, the floor is yours.
Thank you, Dr. Carol, and thank you for everyone for listening. Okay, so I'm going to talk about adult onset hypophosphatasia. I have no financial disclosures. And our objectives today is to know the types of the human alkaline phosphatase and then the structure and function of alkaline phosphatase. And then we'll talk about hypophosphatasia, the definition, clinical features, epidemiology and genetics, differential diagnosis, how to make a diagnosis, and treat hypophosphatasia. So this is the human alkaline phosphatase is two types. One is the tissue-specific alkaline phosphatase, and then the other is the tissue non-specific. And we will be focusing more about the tissue non-specific today. So it's highly expressed in the bone, teeth, and liver and kidney. That's why it's called tissue non-specific. And it's encoded in chromosome 1. Although they're in the difference between the bone, liver, and the kidney mainly comes from the post-translational modifications of the enzyme. Tissue-specific alkaline phosphatase is encoded in a different chromosome, and it's highly expressed in the placenta, intestine, and germ cells. So this is the structure of the alkaline phosphatase. So it's important to note that it's a cell surface phosphohydrolase, and it's bound to the cell surface by GPI anchors. And it's important to know that we need the GPI anchors for the function of the alkaline phosphatase. So that's important to know when we talk about the treatment of hypophosphatasia is that just supplementing the alkaline phosphatase alone is not enough to treat the enzyme deficiency. So it's very important to have the GPI anchors, which helps hold the enzyme to the cell surface. So how is TNAP, which is the tissue non-specific alkaline phosphatase, is involved in bone mineralization? So the bone strength mainly comes from the formation and deposition of the hydroxyapatite crystals. And alkaline phosphatase dephosphorylate inorganic pyrophosphate to inorganic phosphate, which in turn binds to calcium and helps in the development of the hydroxyapatite crystals. So when the alkaline phosphatase is deficient, we will not have formation of hydroxyapatite crystals. So bone mineralization is defective. In addition to that, the inorganic pyrophosphate by themselves are very potent inhibitors of bone mineralization. So having accumulation of the inorganic pyrophosphates inhibits bone mineralization. So alkaline phosphatase also has other important functions. And one of them is it's involved in the metabolism of vitamin B6. And in turn, vitamin B6 is also involved in the formation of multiple neurotransmitters, including GABA and adenosine. So vitamin B6 is transported in the blood in the form of pyridoxal 5-phosphate, which is PLP. And in turn, for the pyridoxal 5-phosphate to cross the blood-brain barrier, it needs to be converted or dephosphorylated to pyridoxal. So when we have deficiency of alkaline phosphatase, we cannot convert PLP to pyridoxal. So we'll have accumulation of PLP, and that will also help us in the diagnosis of hypophosphatasia when we talk about it later. So we'll have accumulation of the PLP, and then it cannot cross the blood-brain barrier, so we'll have defective formation of some of the neurotransmitters. And that will also explain some of the neurological symptoms of hypophosphatasia. It was also proposed that tissue non-specific alkaline phosphatase activation by inflammatory cytokines in the vascular smooth muscle cells helps in the formation and stabilization of plaque. And it was proposed that patients with hypophosphatasia are protected from this effect, so they have less vascular calcification and less plaque formations. But again, we don't have enough evidence to support that. It was just a hypothesis. So I'm going to now start talking about hypophosphatasia. So hypophosphatasia is a heterogeneous, progressive, systemic, and inherited disorder secondary to deficiency or decrease of the serum bone alkaline phosphatase activity. And I like the definition by Michael White. Hypophosphatasia is the last form of rickets to have a medical treatment. So prevalence of hypophosphatasia. So hypophosphatasia was first discovered in Canadian Mennonites. So in Canadian Mennonites, it has the highest prevalence, and it was the affected gene was found in in 2,500 patients, and that is followed by France and North Europe, and then Japan, then the United States, and then Japan. It's also important to note from this slide that the heterozygous form is fairly common. But again, having a heterozygous form of the gene does not mean that the patient will develop the clinical features of hypophosphatasia. So the genetics, it's a loss of function mutation, and there is about up to 400 LPL mutation that have been reported, and it's either can be autosomal recessive and autosomal dominant. And then the severe forms tends to be inherited in autosomal recessive and recessive inheritance. The adult form is male inherited as dominant inheritance. So there is a huge spectrum of phenotypic features of alkaline phosphatase, and that is noted to be secondary to the different concentration of tissue non-specific alkaline phosphatase present. So, for example, in the severe form, there is no any formation. There is a defective formation in the tissue in the alkaline phosphatase. So the alkaline phosphatase is almost absent. And then in the moderate type, which can be inherited as autosomal recessive or dominant, there's some formation of tissue non-specific alkaline phosphatase, but the transportation of the protein to the cell surface is defective, and it gets destructed within the cell itself. And then in the mild type, which is male inherited as autosomal dominant, and that's what we see in male in the adult type, is that there is a defective protein that there is some of it in the cell surface, but it's defective, so its function is abnormal. In addition to that, the defective protein inhibits the formation of another protein, such as the collagen protein. So there's 6 different types according to the phenotypes. There is the prenatal lethal, which is inherited as autosomal recessive. So there is severe hypomineralization and osteochondral spares. There's no dental symptoms. In the perinatal benign, there is bowing of the long bones and a benign postnatal form. In the infantile, there is craniosynostosis, hypomineralization, rickety ribs, and hypercalciuria, and I will talk about details. And in the childhood form, there is short stature, deformity, waddling gait, chronic bone pain, and fractures. In the adult type, that will be the focus of our talk today, there's stress fractures, mainly metatarsal and tibial osteoarthritis, and they may or might not be dental symptoms. And the odontotype is mainly has dental symptoms, and it's secondary to loss of alveolar bone. There is a reduced thickening of the dentin, and there's other dental abnormalities. So these are the possible multisystemic and skeletal manifestation of hypophosphatasia. So in the musculoskeletal, we have recurrent low trauma fractures, we have metatarsal fractures, chronic bone pain, and metatarsal sclerosis and fracture, which is a very common form of fractures, which is the metatarsal fractures. And then there is pseudo fractures, which is one of the characteristics of hypophosphatasia, that we have a loser zone, and I'll also talk about that. And then there's also rheumatological symptoms. There's pseudo gout and calcific periarthritis, and the mechanism for the calcium pyrophosphate crystal deposition mainly comes from the abnormal inorganic pyrophosphate to an organic phosphate ratio, which result in accumulation of calcium pyrophosphate crystals. There is also nephrocalcinosis and acute kidney injury, chronic kidney disease, and there's a lot of mood disorder, fatigue, sleep disturbance, mainly due to abnormal formation of the neurotransmitter that we spoke about. And there's dental features, which is premature tooth loss. So there's loss of the teeth with the root intact, which is a characteristic feature of hypophosphatasia. And there's periodontal disease and abnormal dentition. And we can have different combination of clinical features. So the calcium and the phosphate hemostasis in hypophosphatasia, so there will be hypercalcemia and hypercalciuria with reduced PTH levels. And again, all of these features are mainly depends on the severity. So the mechanism for the hypercalcemia and hypercalciuria is secondary to decreased incorporation of minerals in the skeleton, which leads to elevated calcium and inorganic pyrophosphates, and that in turn leads to reduced PTH levels and hypercalciuria. There is also hyperphosphatemia with elevated TMG-GFR and inappropriately normal FGF23. So it was also proposed that alkaline phosphatase plays a role in reabsorption of phosphate from the kidneys. So there is increased renal reabsorption of the phosphate, resulting in increased TMP-GFR ratio with inappropriately normal FGF23. And that was reported by Michael White. And again, the exact mechanism was not understood. So the clinical characteristics of HPP in individuals who are diagnosed as adults. So this was an interesting study that evaluated 22 non-related patients who presented at the Mayo Clinic between the year 1976 to 2008. And interestingly, the median age of diagnosis was 49 years, so they were not very young, but again, the youngest was almost 35. And then there were only positive family history in 2 patients. 15 out of the 22 were symptomatic at diagnosis. Most of the symptoms was chronic pain, fractures, and 8 of them actually had multiple fractures. And the most common of fractures were at the metatarsals and at the hips and then the wrists. And only 3 of them had dental problems, and 3 of them had pseudogout, but the serum calcium and phosphate in this group were reported as normal. So this is from the surveys of adults with pediatric or adult onset HPP, and again, the surveys did not report who actually respond, who responded and what's the genetic analysis, but most of them did report a lifetime history of fractures, actually multiple fractures, and again, pain was one of the major clinical symptom, and use of an assistive device was also a major concern. The burden of illness with adults with hypophosphatasia. So we can see here that it doesn't matter if the patient had an adult onset or diagnosed as like a pediatric onset. There's a lot of pain, functional disability, social and emotional deconditioning as well. So how to make a diagnosis of hypophosphatasia knowing this huge phenotypic features? So it's one of the diseases that has the greatest range of severity. So we can have any of these clinical features and we can have them separately, not even in combination. So they can just present with low alkaline phosphatase, just present with pseudofractures, just kidney stones, or even pseudogout, and osteoporosis and osteopenia that we will focus on as well. So these multiple phenotypic features actually result in a lot of common misdiagnosis of the disease. The most common misdiagnoses of hypophosphatasia are fibromyalgia, nutritional rickets, osteoporosis, osteoarthritis, XLH, and periodontal disease, if they just had the dental problems. So for the diagnosis of HPP, we have mainly 4 buckets to diagnose HPP, and we have to take all of them in aggregates. So the 4 of them are actually complementary to each other. So there's four main areas of, or four main buckets of diagnosis. We have persistently low alkaline phosphatase, less than 40, and then an assessment of the phosphate esters, which are the substrate of the alkaline phosphatase, which is PLP and high urine phosphoroethanolamine, and then imaging phenotypes and genetic testing. So for the alkaline phosphatase, it should be less than 40, and it should be persistently low. And whenever we have a low alkaline phosphatase, we have to make sure that the lab is reporting it as the agent. It should be reported as agent-specific alkaline phosphatase reference range. So this is from a Wisconsin Diagnostic. They actually adjust the level of the alkaline phosphatase according to age and sex. So we have that already adjusted whenever we have the alkaline phosphatase result. So as we can note here that the children have higher levels of alkaline phosphatase. Males also have higher alkaline phosphatase than females. So that's already automatically being adjusted by the lab. So for the alkaline phosphatase, for what's the definition of persistently low alkaline phosphatase? It should be it's defined as at least 2 low values below within 6 months. And whenever we have a low alkaline phosphatase, we do not need to get bone-specific alkaline phosphatase because the bone-specific and the liver-specific are encoded by the same chromosome, so it will not add to the assessment. And then again, alkaline phosphatase below 40 is not conclusive for the diagnosis, but it should raise the suspicion for presence of HPP. And that being said, that the level below 40 sometimes might not be flagged in the lab value, so we should look for it. We have just to be careful even if it's not flagged. So the differential diagnosis of low alkaline phosphatase is also very wide, but the diseases that cause persistently low alkaline phosphatase are actually not many. There is only 3 of them: hypophosphatasia, and then cleidocranial dysplasia, and these patients will mainly have obvious skeletal dysplasia. And then there is the disease that's called Miscellany joint disease, and it's endemic in South Africa. And then transiently low alkaline phosphatase are a number of actual endocrine problems. So we have it with Cushing's disease, severe hypothyroidism, we also have it with celiac disease, vitamin D intoxication, and interestingly, alkaline phosphatase can also be low after bisphosphonate therapy. So I think it's important to get a baseline alkaline phosphatase before starting bisphosphonates. And it could be precipitously low in patients who have major trauma, major surgeries, and patients with multi-organ failure and sepsis, and it's starvation as well. So I'll go to the next diagnostic modality that we have is measurement of pyridoxal 5-phosphate. So unfortunately, we don't have this done at our lab, and it's usually a send-out test. So pyridoxal 5-phosphate, again, is one of the substrate of alkaline phosphatase. It's the transportation form of vitamin B6, and it's converted to pyridoxal in order to cross the blood-brain barrier. But so for measuring PLP, we should have a fasting sample. The specimen should be protected from light, and the reference interval is again specific to each lab, and it might be influenced by the albumin level because the PLP is bound to albumin, and patients should be off vitamin B6 for about 2 weeks. And then measurement of urine PAA, phosphoroethanolamine. So extracellular PAA mainly originates from the degradation of phosphatidyl inositol, which couples many proteins, including the ALP. And in patients who have HPP, it was noted to be the blood and the urine levels are both elevated. And again, we don't have PAA in our labs. It's also a send-out. So these are the lab characteristics of the same patients who presented to Mayo Clinic, who were 22 patients unrelated. So we can see here that in symptomatic patient, the minimum serum alkaline phosphatase was 42, and again, the mean ALP was just borderline. It wasn't fair. It wasn't low, but in some of the patients, it was low as 15. What was helpful in the diagnosis of these patients that both the PLP and the urine PA was elevated in both symptomatic and asymptomatic patients. So definitely getting serum PLP and urine PA will support the diagnosis of hypophosphatasia. So so these labs can actually differentiate hypophosphatasia from other metabolic bone disease. So alkaline phosphatase is low only in HPP, and it's actually high in nutritional rickets, which is also one of the common misdiagnoses. And then PLP and urine PA are also high in HPP. Calcium and phosphate can be high or normal, which are low in nutritional rickets, and they can be normal. And then we have low phosphate in XLH. And then the parathyroid can be normal or high. Then parathyroid hormone is actually high in both nutritional rickets and XLH. And the vitamin D is normal in HPP, in contrast to nutritional rickets and XLH, which can be, it's low in nutritional rickets, of course, and it's low to normal in XLH. And then we will come to the fourth diagnostic modality, which is imaging characteristic. And so we can see here the loser zone or the pseudo-fracture, which is a hallmark of osteomalacia secondary to HPP. So osteomalacia secondary to vitamin D deficiency and other causes of osteomalacia will cause pseudo-fracture mainly in the femoral neck. Unlike in HPP, it's mainly laterally and proximally to the subtrochanteric region. And that actually makes it very similar to the pseudo-fracture that happens with bisphosphonates. Then we'll talk about genetic testing, which is the fourth diagnostic modality. So unfortunately, genetic testing does not exclude or confirm HPP. So the genetic screening is usually performed by sequencing the ALPL coding sequence in the intron and extron borders. But as we can see here in the ALPL gene, that we can actually have mutations throughout the gene, and sometimes that is not being screened for within the gene. So definitely genetic testing can miss HPP, and if it's positive, it will support the diagnosis. But again, negative genetic testing cannot exclude HPP. So HPP and osteoporosis. So we have to note that the peak bone density is actually not reached in patients with HPP and other endocrine problems in both males and females. And that's also an interesting study from Sheffield group in UK about the prevalence of HPP in UK in 2021, and they noted about 20 patients who presented to Sheffield group, and they compared this to patients with osteoporosis, 21 patients with osteoporosis, and they actually found that the imaging characteristic helped in differentiating HPP from osteoporosis. Patients with HPP had more metatarsal fractures and femoral shaft fractures compared to the compression fracture that we see with compression vertebral fracture that we see with osteoporosis. And in the same group, they noted that the alkaline phosphatase the median was 43, so it's towards the lower level of normal, and again that might not be flagged, but it's borderline, it's towards the end of the normal. And then the PLP was actually elevated in these patients in the HPP group. So HPP management is also 4 buckets. So there's the enzyme replacement, conventional therapy for low bone densities, but this is the vitamin and calcium supplements that we use for osteoporosis. And we have bridging therapy mainly for patients who have pseudo fractures or stress fractures, and involvement of a multidisciplinary team is also important. So historical enzyme replacement, that was actually interesting that in the 1980s they used the blood from patients who had Paget's disease, but of course that did not work because they didn't have the GPI anchor to anchor it to the cell surface, so the alkaline phosphatase will not have the normal function. They also used bovine PTH analogs, and they also used purified human placental ALP. but again, without clinical radiographic improvement. So what we have now is aspartate alpha or extrinsic. So it's a tissue non-specific alkaline phosphatase that is coupled to a Decad's aspartate motif that targets the bone, and that's how it helps in keeping the tissue non-specific alkaline phosphatase on the cell surface so it can have its function. And when we start patient on extrinsic, that's how we follow their response to treatment by this 6 minutes walking test and the timed up and go test, and we can see starting from 3 months we can notice improvement in the functional in the function of the patient. And it's also been studied in 3 patients who had fractures, and the evaluation of the bone healing in these patients showed improvement in both in the fractures. So it seems that it does help with healing of the fractures as well. And then here they mainly looked for excessive mineralization with extrinsic or aspartate alpha. So they did start, so they included patients who they followed for about 5 years. And then they started with a normal bone mineral density. And these patients were less than the age of 50. And they found that there were no excessive mineralization in the femoral neck or the spine. But it was not studied in patients who have low bone density. So unfortunately, you know that extrinsic is out there and it's awesome, but it's very hard to be covered in the United States. And to have it covered, we have to have diagnosis of HPP less than the age of 18, and we should have all of the clinical features of HPP present. Low alkaline phosphatase, elevated PLP, elevated urine or serum PA. And again, it's only approved for 6 months. So every 6 months, so it's approved for unlimited amount of time. So it might not be approved for patients who are diagnosed more than the age of 18. So we need to hate it a little bit. So these are the adverse effects of aspartate alpha. So it has major injection site reactions, lipodystrophy and ectopic calcification, mainly in the site of the injection and in the lens. So some patients reported lens calcifications. Vomiting and systemic hypersensitivity reactions are the main side effects of aspartate alpha. And with the aspartate alpha treatment, they noted alkaline phosphatase to be very high, like it can reach up to 1,000, and the effects of very high alkaline phosphatase has not been studied yet. So the medical management conventional therapy is vitamin D and calcium. So it's actually best avoided in HPP patients because it can lead to hypercalcemia, kidney stones, and nephrocalcinosis. So unless the patient had an obvious deficiency, it's not recommended to start vitamin D and calcium supplements in these patients. And bisphosphonate therapy actually worsen. We'll talk about that, but I know it's a scary thing in HPP patient because it might worsen the hypomineralization, and it also can result in atypical femoral fracture. So and the reason is that bisphosphonates are analogs of inorganic pyrophosphate, and as we mentioned earlier that inorganic pyrophosphatates are actually potent inhibitors of mineralization, and they can also bind to the residual zinc, magnesium, and other minerals, and it can make the remnant mineralization even worse. So this is an example of a patient who had bilateral atypical fractures with bisphosphonate therapy. So that patient that was a 55-year-old woman who received 4 years of alendronate and then about 2 years of zoledronic acid for osteoporosis. And then she did have bilateral femoral fractures. But that being said, they might not be that scary. It was actually proposed that in patients who does not have osteomalacia in bone biopsy, bisphosphonate use can be considered. And that was proposed after a patient who was diagnosed with HPP was on alendronate for about 5 years without any evidence of fractures, and they reported actual improvement in her bone mineral density. And in that patient, they did a bone biopsy, and it showed features of osteoporosis rather than osteomalacia. So it was suggested that if we excluded osteomalacia by bone biopsy, bisphosphonate might be safe in this scenario. And then medical therapy, bridging therapy by teriparatide, which might be our only option with HPP. So, but the main thing is that teriparatide response is very limited after discontinuation of the teriparatide. So there were 8 patients with adult HPP. All had fractures or pseudo-fractures, were treated with teriparatide, and then their fracture healed in a very short time with no any fracture occurred while on teriparatide therapy. But however, the beneficial effect seems to decrease when teriparatide was stopped. And about 3 out of the 8 patients had interesting course of treatment. 3 of them had fractures after discontinuation of the teriparatide, and then teriparatide was restarted again. So it was proposed treatment with intermittent teriparatide. For example, Camacho gave 3 of her patients teriparatide for about 2 years, and then she stopped and then restarted again in about a few months for about 2 years. So there's an idea about intermittent therapy with teriparatide, especially about the black box warning about the osteosarcoma was removed. So this was the first patient who was treated by teriparatide. So teriparatide was started after she had a proximal femoral fracture, and then we can see that the fracture has healed within about 5 months. And then what do we have for future treatment? So there is a treatment that it's actually approved in Europe now. It's an anti-sclerostin inhibitor, monoclonal antibody, anti-sclerostin monoclonal antibody. So sclerostin inhibits osteoblast. So when we have the anti-sclerostin antibody, we will decrease the inhibition of the osteoblast, and then the level of alkaline phosphatase might be increased with that. So there is a BPS 804, or it's called estrosumab, and it was tried in 8 patients with mean age of 47, and they received 3 ascending doses with improvement in the ALP enzyme activity between day 2 and day 29, and lumbar bone mineral density and femoral bone mineral density was also increased by the end of the study. And then this is just a summary of the management is that we need a multidisciplinary team, including the nephrologist, the endocrinologist, the dentist, and a clinical care coordinator if the patient is immobile. No, that's about it. Any questions?
So feel free to enter questions in the chat box if you're remote, or unmute, or if anybody in the room has questions. I guess I'll start. I mean, we always kind of say the traditional thought of the no bisphosphonates in these patients because it looks like an organic pyrophosphate.
Mm-hmm.
Is that really, should it be any anti-resorptive? So something like denosumab, we would use that, even though that is not anything like an organic pyrophosphate.
I'm not sure about the denosumab, but definitely bisphosphonate are inorganic, are analogs of pyrophosphate, so that they will inhibit the mineralization more, but I'm not sure about the denosumab.
Can I make a comment?
Sure.
So the denosumab question is a good one. I don't know the answer, but I would be reluctant to use a potent anti-resorptive agent in a patient that might have a mineralization disorder. And if you were going to, and if you said the patient can never take a bisphosphonate, then you would be saying you're putting the patient on denosumab for the rest of their life. Because you can't stop it without a bisphosphonate.
Yeah.
So there's certain practical things. So if it's a 40-year-old patient or 60-year-old patient, even, you're going to say, okay, you're going to need denosumab for the next 30 years. That's the problem. A little comment about enzyme replacement therapy, which is about $1.5 million a year. It is life-saving in the infants, dramatically life-changing in the children. And, Mike White, will show the videos of this stuff, and it's really incredible. In adults with clear childhood onset disease, so at age 3, they were diagnosed with fractures, and the diagnosis was made, and they've had many, many fractures. I have a few such patients. They seem to get a very significant benefit too. The real question is these patients with a low alk phos, maybe a stress fracture sometime in their life, and they have some vague symptoms, and to do genetic testing, and they have dominant disease. And I don't know the answer to that. And if you look at like Tom Weber's study with the adults, and they say adults with pediatric or adult onset, if you actually look at them, 75% of those people had childhood onset. And the data on true adults with adult onset disease is really limited. And it's hard to justify that expense. So, and it's not approved. I mean, trying to get it approved in an adult without at least a fracture as a kid, is almost impossible.
Joe, is the cost, this is Vidya, is the cost true cost, or is that the cost of the drug company? I mean, is there ever a chance of these orphan drugs would ever, I mean, it's just a philosophical question, but there are lots of different diseases like this where the cost of therapy is so astronomical. Would it, let's say 10 years from now, would become, because I have to think that the true cost of making this and stuff is not as high, right?
So unless society decides to support the development of the drugs, right? So if a drug company develops it, it costs them billions of dollars, they got to recoup it. So I am sure the charge for that is all because of the development. I'm sure the true cost is way less than that. I wouldn't even know, Vidya, but I'm sure it's a lot.
Orphan drugs are all orphan diseases.
Yeah.
And often, I don't know about this company, but I mean, they're often willing to get patients drugged. I mean, they obviously recoup some costs from the other people that are getting it paid for. So,
yeah, most of the cost is development. The other comment I'll make is that even the PEA, Fergus McKiernan did a study of heterozygotes, and it was elevated in 75% and normal in 25%. So, there's a place, what's the Prevention Genetics will do this for a patient without insurance for $200. It's cheaper than the urinary PEA. So I think in a patient with, I'll ask Randa if she agrees with this, with a clinical scenario compatible with a low alk phos and a positive genetic test, I think that's enough. I know there's this issue of whether you could have intronic and all kinds of, regulatory regions and stuff like that. So I'm sure we're missing some cases who have mutations in places that aren't sequenced.
And I have one of those patients, Joe, a patient who had negative genetic testing, all the classic symptoms of HPP, low alk phos, and even the B6 level was not high, was normal, but she fortunately was able to get it approved. But that's difficult.
Yeah, I think that, I don't know who here knows, there may be somebody on the audience who knows more about genetic testing, but now they're talking about moving from whole exome sequencing in rare bone disease to whole genome sequencing. So they sequence everything. And maybe with that, they'll find more of these intronic or regulatory. Yeah, thanks for putting that slide back up, Rhonda. So Rhonda, I saw a patient this morning. In my clinic today, I saw 2 patients with hypophosphatasia. And one of them is a 50-ish-year-old woman. She has thalassemia. And I think pretty significant thalassemia. And I think that's why she has osteoporosis. Well, we had asked her to get genetic testing. I can't remember all the B6 and all the other stuff because she had persistently low alk phos. And she finally gets the genetic testing and it's positive. And I saw her this morning. But the other thing that's happened in the past 6 months is she's had 2 compression fractures, which she's not had before. I think I think she had a metatarsal fracture in the past, and now she has compression fractures, which your slide showed what was my impression, that this is not typical for hypophosphatasia. Am I correct?
Like where were the locations of was it in the subtrochanteric area?
No, compression fractures, spinal compression fractures.
So that was.
She had an old metatarsal stress fracture and now had spinal compression fractures, which, if I understand your slide correctly, is not common in hypophosphatasia.
Yes, it's more common in osteoporosis, as was reported from the Sheffield group in the UK. But I think so. The fractures that were common in HPP were mainly the metatarsal foot or metatarsal or the femoral shaft fractures. Vertebral fractures were more commonly seen in osteoporosis.
So I think her primary driver of this pathology is her osteoporosis related to thalassemia. And she's been worked up, and I did a bunch of other tests today that I will probably be normal. And my plan, she does not have anything to suggest childhood onset. My plan is to give her teriparatide or abaloparatide. And then exactly what you talked about, and use it intermittently.
Correct.
Anybody have other ideas?
I agree with the use of teriparatide, Joe, but how intermittently you're going to use it?
I don't know. I was going to give it for 2 years and then wait, or maybe 18 months and then stop for 6 to 12 months and give it again, but I don't know.
Is there any data for Romo?
No, but I think Randa showed a study on a similar drug. And this drug that she showed is also being studied in setrusumab. It's being studied in OI. And there are phase 3 trials in people under the age of 25 with OI now ongoing. I don't think they've started the above the age of 25 study yet. So that's another interesting possibility. Yeah.
Other questions for Randa at all?
Any other ideas?
About your patient, Joe, I was wondering if after those 2 years of teriparatide, maybe you can try to get the enzyme approved and you do teriparatide enzyme.
Yeah, you know what? That dawned on me. And it's interesting. The reason I decided to go with teriparatide or abaloparatide is it seems like it's something I could get approved relatively quickly. And I knew that if I went for enzymes, that it would be a battle and would probably take, even if I ever got it approved, probably 3 to 6 months. The other thing is, her big thing right now is compression fractures. And I think, teriparatide and abaloparatide are really good at preventing compression fractures. And so I thought that was the most urgent issue. And that's why I decided to go with that. But I do think the idea of either intermittently using enzyme if you can get it, or Romo, hard for me to believe that setrusumab would be any different than Romo, but I don't know. And it's interesting that the company that has this drug is going for the rare bone disease market. And it's hard for me to believe that they'll be able to price it more than Romo, because I would think most, you'd be able to just use Romo. I don't know. Randa, that was excellent. And I think you pointed out a lot of important, in the physiology of it and in the ectoenzyme nature and everything. So that was terrific. The other thing, one other comment. The alk phos can sometimes be, and I'll get these urgent messages from doctors or from patients. My doctor's upset because the alk phos is 6,000. It could be off the walls. It's an irrelevant test once you put the patient on this drug.
Great. Thanks, Randa.
Yeah, thank you. That was really terrific.
Thanks, everybody.
Thank you.